Well, good afternoon, and thanks so much for joining us today. Today's session is focused on congenital syphilis, and it is a rescheduled session from January. Today, we have Dr. Jason Zucker presenting. Dr. Zucker is an assistant professor of medicine at the Columbia University Irving Medical Center and the assistant medical director of the New York City STD Prevention Training Center. Trained in adult and pediatric infectious diseases, he has extensive experience providing sexual health care to patients of all ages, as well as providing technical assistance and training around sexual health to clinicians. His research interests focus on how technology can be used to optimize the cascade of care for adolescents and young adults at risk of HIV and STIs. Welcome, Dr. Zucker, and thanks so much for your presentation today.
Thanks so much, Gary. Just some housekeeping from the beginning of the talk. Please make sure to remain on mute and send your questions in using the question and answer tab. For CME, it's available through the CDC Training and Education online system. Instruction for completing the evaluation and obtaining CE will be emailed to attendees of the webinar. And just so everyone knows, today's webinar is being recorded. So good afternoon, and thank you all for taking time out of your day for this important topic. I have the lucky opportunity to be an adult and pediatric
Dr. Zucker, for some reason your sound has gone out. We can't hear you. We can hear you now.
You can hear me now?
Yes.
That's weird. Okay, where did I leave off?
I think you were
probably about infectious diseases.
Okay. So why don't we just take a step back and we'll do objectives for today. So the objectives for today are to discuss syphilis history, microbiology, and recent epidemiology, identify the clinical picture and treatment recommendations of congenital syphilis, and review the screening recommendations for syphilis in pregnancy. And as a pediatric infectious disease fellow or attending, you will get called for congenital syphilis. These are just some reports from the last 3 months. Mississippi with a 900% increase, California with congenital syphilis rates soaring, and St. Louis with over a 500% increase in congenital syphilis. And this is all in the context of STDs in general increasing. The CDC released the 2021 State of Sexually Transmitted Diseases in the US, showing that some STIs continue to increase, including a 25% increase in cases of gonorrhea since 2017, a 68% increase in cases of syphilis since 2017. And that led to a staggering 185% increase in congenital syphilis since 2017. And it's really for that reason that I'm here today to talk with you about congenital syphilis. Before I dive in, I think it's important to know that it didn't have to be this way. In fact, in 1999, there was a national goal to reduce primary and secondary syphilis cases to 1,000 or fewer, and increase the number of syphilis-free counties in the United States to 90% by 2005. And what they said back in 1999 holds true today. As we approach the end of the 20th century, the US is faced with a unique opportunity to eliminate syphilis within its borders. Syphilis is easy to detect and cure, given adequate access to and utilization of care. Nationally, it's at the lowest rate ever recorded, and it's confined to a limited number of geographic areas. The last epidemic peaked in 1990 with the highest syphilis rate in 40 years. Elimination of syphilis would have far-reaching public health implications because it would remove 2 devastating consequences of the disease: increased likelihood of HIV transmission and compromise the ability to have healthy babies due to spontaneous abortions, stillbirths, and multi-system disorders caused by congenital syphilis. This chart shows the reported cases of syphilis by stage of infection from 1941 through 2019. And I placed a blue arrow over that peak from 1990 and a green arrow over our current day. And as you can see, we're not far away now from that peak in 1990. And this second chart shows the same data from 2010 through 2019, or 2021, sorry. So you can better see the dramatic rise in cases of total syphilis during the more recent period of time. In particular, since 2012, cases have risen from 23.4 per 100,000 to 51.5 per 100,000. And we know that syphilis cases are not distributed equally. Rates are higher amongst individuals by their gender, age, and race ethnicity. And in these two charts, you can see rates of syphilis by age and sex at birth. On the left-hand side are males, and on the right-hand side are females. Most important for today, you can see that in both men and women, these rates are highest amongst those who are younger, with the peak in females being their childbearing years. And that data doesn't tell the whole story, as you can see here. While the rate amongst men is approximately 24.4 per 100,000, up 45% over the past 5 years, the rate for women is 7 per 100,000, up 204% over the past 5 years. What you can see on the chart on the right is reported syphilis cases by sex and male to female ratios. And as you can see from that bright pink line, the male to female ratio in the United States is declining. Because although infection rates in both men and women are increasing, the infection rate in women is increasing much faster than that of men. Mirroring this overall trends in US syphilis incidence, you can see that rates of primary and secondary syphilis among women of childbearing age and congenital syphilis have been increasing, with higher numbers of reported cases across all regions of the United States. In fact, since 2015, cases of congenital syphilis have risen from 12.5 per 100,000 to 48.3 per 100,000. So why do we care? Why does this all matter? Well, there are lots of reasons, but in this case, it's the fact that syphilis can infect the placenta and through transplacental infection affect the baby. Transplacental transmission to the fetus can occur from approximately the 9th to 10th week of gestation and can occur at any stage of disease. Fetal abnormalities result from the robust inflammatory response and therefore are most pronounced after 20 weeks of gestation, since the fetal immunologic response is poorly developed in the first half of pregnancy. Congenital syphilis occurs when syphilis is transmitted from a pregnant woman to her fetus, and this can have devastating outcomes, including congenital infection, miscarriage, stillbirth, preterm birth, impaired fetal growth, and neonatal mortality. In fact, it's actually recommended that any woman who delivers a stillborn infant after 20 weeks be tested for syphilis. And the risk of infection to the neonate is related to a few factors. The first is the stage of syphilis, with earlier stages being higher risk than later. Maternal infection later in pregnancy being higher risk. And finally, what I'll highlight a lot today, failure to adequately test and treat maternal infection leads to increased risk. The diagnosis of congenital syphilis can be difficult, as maternal non-treponemal and treponemal antibodies can be transferred through the placenta to the fetus, complicating the interpretation of serologic testing. Evaluation and treatment decisions are really based on 4 steps. First is identification of syphilis in the mother. Second is to determine if maternal treatment was adequate. Third, looking for the presence of clinical, laboratory, or radiographic evidence of syphilis in the neonate. And 4, comparing maternal and neonatal non-treponemal serologic titers. And with those 4 thoughts in mind, I'd like to introduce you to 3 patients. These are all based on real patients. However, details have been changed to protect patient privacy. The first patient is Jen, a 34-year-old bisexual female, pregnant with her first child. Her partner of 10 years is a 36-year-old bisexual man, and they're in a committed open relationship where they both have same-sex partners. She presents for prenatal care at about 10 weeks gestation. Next is Eva, a 29-year-old female pregnant with her first child. The baby's father is what she described as a fling, and she does not intend to be involved in the pregnancy. She presents for prenatal care at about 12 weeks gestation. Finally, meet Alex, a 24-year-old female pregnant with her first child. She's pregnant with her high school sweetheart, and neither of them has had any other sexual partners. So who should be screened for syphilis? Well, I think by now you've probably guessed, and I'm going to say that they all should be screened for syphilis. To start with, we can look at the general recommendations in screening for syphilis. Interestingly, there are currently no national recommendations for routine screening amongst non-pregnant women, which is obviously a problem given the increasing rates amongst women I described earlier. In general, they do recommend screening at least annually among sexually active persons if at increased risk. And so please keep that in mind when thinking about your female patients. In general, I recommend that if you're screening for STIs, consider screening for HIV and syphilis as well. For pregnant women, they recommend screening at the first prenatal encounter plus the third trimester or 28 weeks at delivery if increased risk or in a community with high prevalence. I will say now that most jurisdictions now recommend first and third trimester testing due to the increased risk and the rising cases of congenital syphilis. The reason testing is so important is that the cost of screening is low and morbidity of a misdiagnosis is high. Additionally, by providing recommendations for universal screening, you can help reduce stigma. So as a reminder, we should try to do complete STI testing on all of our pregnant patients. I'm highlighting those results here, but don't forget about Hep B, Hep C, and other infectious diseases that I won't cover today in the interest of time. So in our first patient, Jen, she was HIV antibody antigen negative, 3-site gonorrhea, chlamydia, NAT negative, and our RPR was reactive with a titer of 1 to 1. Our second patient, Eve, was HIV antibody antigen negative, 3-site gonorrhea, chlamydia, NAT negative, and RPR reactive with a titer of 1 to 8. And our third patient, Alex, was again HIV antibody antigen negative, 3-site gonorrhea, chlamydia, NAT negative, and RPR reactive with a titer of 1 to 1. So with that said, what else do we need to know to properly evaluate our patients and their babies? Well, as I said before, the first step is to identify syphilis in the mother. And to do that, we need to do testing. The tests used for diagnosing syphilis are the same in both pregnant and non-pregnant women. There are two types of tests for syphilis: non-treponema quantitative tests and treponema qualitative tests. I have spent more than an hour plus talking about just testing for syphilis, but in the interest of time and that not being the focus of today, I'll remind you that there are two different algorithms. The traditional algorithm, which starts with a non-treponemal test and then reflexes to a treponemal test if reactive. In this case, if it's reactive, there's evidence of syphilis infection. But what you don't know is whether or not it's current infection or prior treated infection without additional history. In the reverse algorithm, it starts with a screening treponemal test or a qualitative test, which if reactive goes to the non-treponemal test. If reactive, that's evidence of syphilis infection, with the same caveat as before, as you don't know whether that's new infection or prior infection without additional history. If it's non-reactive, it does go to a second treponemal screening test, where if it's non-reactive, you're worried about a false positive versus early infection, or if it's reactive, it's evidence of syphilis infection as well. In addition to serologic testing, there are also other signs of congenital syphilis. Fetal infection may be suspected if there are characteristic non-specific findings on ultrasound exam after 20 weeks of gestation. Hepatomegaly and placentomegaly are early findings, while anemia, ascites, and hydrops occur later in the course of infection. Abnormal ultrasounds are not diagnostic of fetal infection, and normal ultrasounds do not exclude fetal infections, but they may be a sign that it's something to look out for. Now return to Alex, who you may remember as having a baby with her high school sweetheart. As neither of them have had any other partners, they're convinced that this had to be a false positive test. Her RPR was positive, but the confirmatory treponemal testing was negative. So this is likely a false positive, which is more common in pregnancy. A positive low titer non-treponemal screening test can be considered a transient false positive due to pregnancy if the confirmatory testing is negative, as in this case, and the patient is asymptomatic and at low risk of infection based on history. Again, is consistent with this case. Repeating the RPR now is likely not helpful, as these can remain positive for up to 6 months. However, all women with a false positive in pregnancy should have a follow-up after delivery. However, in this case for Alex, this means that the baby does not need further workup since she was never positive. So in this case, we did not identify syphilis in the mother. But what if mom had syphilis? Well, in that case, the next thing you need to know is whether maternal treatment was adequate, and adequate treatment requires understanding the proper staging of syphilis. This diagram is from the New York City STD Prevention Training Center and New York City Department of Health syphilis monograph that I know we link to in a variety of places. And it's important to note that staging is not affected by pregnancy. It starts with the incubation period. And as a reminder, the incubation period can be up to 90 days long. That means that if you have a patient who's exposed to syphilis, we do need to treat empirically because we don't want to wait 90 days to see whether or not they turn positive. Primary syphilis is identified by local symptoms. This is traditionally the painless chancre we think of as typical for syphilis that occurs at the site of inoculation. It is important to note that the updated STI guidelines do highlight that primary syphilis can present atypically with either painful or multiple lesions, particularly with rectal disease. I also like to highlight that traditionally these are painless ulcers, which means that if they're not in an easily visible spot, like the rectum, vagina, or oral cavity, they may not be noticed by the patients. Secondary syphilis has symptoms. This is where we generally think about rashes on the palms and soles, or other disseminated symptoms like fevers, chills, hepatitis, and other symptoms. Latent syphilis is by definition asymptomatic. Early latent is when it's possible to document a non-reactive syphilis serology within the past year, or a history of symptoms of early syphilis within the past year. Otherwise, the disease is considered late latent or latent of unknown duration. And these designations are important because they determine what is adequate treatment for syphilis. And so in treating syphilis, you treat by stage. This is the standard treatment guideline for treating syphilis both within or not within pregnancy. And the first thing I want you to notice is that there's no alternative regimens in pregnancy. For women with a history of penicillin allergy, they recommend desensitization and treatment with penicillin. This is because non-penicillin regimens are either contraindicated in pregnancy like doxycycline or lack sufficient data for efficacy like ceftriaxone, or do not cross the placental barrier completely like azithromycin, and therefore are not recommended for pregnant women. Otherwise, treatment looks similar to that for non-pregnant patients. It's a single dose of PENG for incubation or exposure, primary, secondary, and early latent syphilis. 3 doses 1 week apart for late latent and late of unknown duration. And then IV penicillin for 10 to 14 days for neuroocular, otic, or tertiary syphilis. However, there is one difference for pregnant women compared to the traditional guidelines. The CDC recommends considering additional therapy for women who have primary, secondary, early latent syphilis with a second dose of PENG 1 week after the initial dose. I'll be honest, this is based entirely on PK/PD data that does show altered penicillin levels in pregnant women. There's no good efficacy data and no randomized controlled trials. But when OB asks me, I generally recommend that it be done. Given the rising rates of congenital syphilis, I think it's better to be safe than sorry to give an additional dose of penicillin in these cases. So going back to Eve, her labs were notable for a positive RPR titer at 1 to 8 in her first trimester, and confirmatory testing was positive. On further history, she'd never been tested for syphilis before, and so she received PENG intramuscularly weekly for 3 weeks for possible late latent syphilis. So how do we determine if maternal treatment was adequate? Well, we need to know the symptoms at the time of diagnosis and a history of prior testing for proper staging. We need to know the number and timing of any treatment given to confirm appropriate treatment. And finally, we need to think about the chances of reinfection, including whether or not the patient's partners were treated as well. As syphilis titers change slowly, adequate treatment is based entirely on whether they receive the appropriate treatment for their stage. However, one additional thing you may need to understand to properly stage syphilis is how to interpret quantitative RPR titers. For example, in the case of Jen, her RPR is reactive with a titer of 1 to 1 and a positive TPA. However, when you obtain outside records, Jen was treated 1 year ago for a titer of 1 to 64 with 3 shots of penicillin G, each exactly 7 days apart. Does that mean Jen needs to be treated again, or is she fully treated? So treatment failure is defined as persistent recurrence of signs and symptoms, or a sustained greater than 2 times dilution following treatment, or failure of non-treponemal titers to decrease by 2 dilutions 6 to 12 months after treatment. In the case of latent syphilis, it's development of signs or symptoms greater than 2 or a sustained greater than 2 times dilution following the initiation of treatment. Or if the initial titer is greater than 1 to 32, failure of the titer to decrease by greater than 2 dilutions by 12 to 24 months after treatment. What does all this mean? Well, let's take a look at titers. Interpreting quantitative syphilis titers are important. Quantitative testing involves serial dilution of serum specimens to determine the amount of non-treponemal antibody present. Non-treponemal test antibody titers are used to follow both treatment response and look for reinfection. A 1 dilution change is a 2-fold increase or decrease in titers, and this may or may not be significant. However, a 4-fold change or a 2 dilution change is always considered abnormal, or is always considered a significant change. This demonstrates a clinically significant difference between 2 non-treponemal tests. So for example, if you go from 1 to 16 to 1 to 32, that's a 1 dilution change or a 2-fold increase or decrease in titers. As compared to a 1 to 8 to 1 to 32, or a 1 to 32 to 1 to 8, which is a 2 dilution or 4-fold change. Non-treponemal titers usually decline after treatment. Non-treponemal test titers usually decline after treatment and might become non-reactive with time. However, in many people, non-treponemal antibodies persist for a long period of time, a response referred to as the serofast reaction. Sorry, just give me 1 second. I apologize. I apologize for that, everybody. That's going back to Jen. So obtaining outside titers for Jen, she was treated 1 year ago for a titer of 1 to 64 with 3 shots of penicillin G 7 days apart. Her titer has dropped from 1 to 64 to 1 to 1, which is more than a 4-fold or 2 dilution decrease, and no further treatment was offered. However, she returned at 32 weeks. She was asymptomatic, but repeat screening labs were notable for reactive RPR and an RPR titer of 1 to 16. This represents a more than 4-fold increase from her prior 1 to 1, and she was treated with PENG 2.4 million units IM for early latent syphilis. So now that we've talked a lot about syphilis in the mother, it's time to talk about the children. And as the Red Book has always said, no newborn infant should be discharged from the hospital without determination of the mother's serologic status for syphilis. I showed this slide earlier to highlight the increasing rates of all primary and secondary syphilis, as well as congenital syphilis cases amongst women in the United States. But while we all know that cases are increasing rapidly, the real question is, why are we missing opportunities to prevent congenital syphilis? So this chart shows missed prevention opportunities among mothers of infants with congenital syphilis from 2017 through 2021. Over the past 5 years, the most common cause for missed prevention opportunities were those with no timely prenatal care or syphilis testing, 38%. What's interesting is that has flipped from pre-pandemic, where what's now the second most common cause, mothers who had testing but no adequate treatment. And you wonder if this flip could have been due to decreased access to care during the pandemic. The third most common cause is late identification of seroconversion during pregnancy, which is why many states and the CDC now recommend first and third trimester testing for those at risk. Fourth, no timely syphilis testing despite receipt of timely prenatal care. And finally, the least common cause is clinical evidence of congenital syphilis despite maternal treatment completion. So as you can see, if you complete maternal treatment, you are least likely to develop congenital syphilis. So we've already covered the mother, as identification of syphilis in the mother and adequacy of maternal treatment is the first step in understanding congenital syphilis diagnosis. And treatment, the next steps focus on the child themselves. So the pathophysiology of congenital syphilis is fascinating. At the onset of congenital syphilis, spirochetes are liberated directly into the circulation of the fetus with widespread dissemination to almost all organs. The clinical manifestations result from the inflammatory response and can be varied. The first step is looking for clinical symptoms, and these are just some of the most common manifestations of clinical syphilis. Hepatomegaly occurs in almost all cases of congenital syphilis and is associated with jaundice and cholestasis, as well as elevated liver enzymes. Syphilitic rhinitis usually develops during the first week of life. It is more severe and persistent than the nasal discharge of the common cold, and the nasal discharge actually contains spirochetes, is contagious, and can transmit infection by direct contact. The bold ones all contain spirochetes that can be infectious and require contact precautions. An examination looking for congenital syphilis needs to be complete because, as I said, syphilis can affect any organ. I also put some of these classic images from the CDC website, including rhinitis with mucopurulent discharge, typical desquamating and maculopapular skin lesions, punched out pale blistered lesions, mainly on the ears and nasal bridge, and desquamation of the palms and soles. Hepatosplenomegaly and jaundice in infant with congenital syphilis. The black markings indicate liver margins. X-ray of bone abnormalities include syphilitic metastasis in an infant with diminished density in the ends of the shaft and destruction of the proximal end of the right tibia. And there are many more symptoms I'm not going to go into today. However, this is a page from our syphilis monograph on our website. But you don't necessarily have to have symptoms of congenital syphilis to have congenital syphilis. This slide shows the proportion of individuals with congenital syphilis who are alive without documented signs and symptoms, which is the largest dark green area. Then there's alive with some signs or symptoms, which is the lighter green area, and infant deaths and stillbirths, which is the blue area. In addition to clinical signs and symptoms, you also have to look for lab signs and symptoms of congenital syphilis. These can be subtle findings like anemia, thrombocytopenia, leukopenia, leukocytosis, or CSF fluid abnormalities, or a positive CSF VDRL. And finally, radiographic findings like periostitis, metaphyseal serration, and destruction of the upper medial tibia, which can all be diagnostic for congenital syphilis. And the final piece of information you need to put this puzzle together are a comparison of maternal and neonatal non-treponemal titers. These need to be from neonatal serum and not cord blood due to contamination from maternal blood in cord blood. And the goal is to compare maternal titers and neonatal titers with a focus on whether or not the infant titer is 4-fold higher than the mother's. And so now that we've reviewed the workup, what will each of these babies need? As a reminder, in the case of Jen, She was treated with penicillin at 32 weeks, and her baby was born prematurely at 34 weeks via C-section due to fetal distress. The baby's exam at birth was normal. Eve was treated with penicillin at 12 weeks, retested at 28 weeks, and her RPR was down to 1:1. The baby was born at 38 weeks via normal spontaneous vaginal delivery, and exam was normal. And finally, Alex was not treated as she had a positive RPR and negative TPA, and her baby was born at 40 weeks via C-section for failure to progress with a totally normal exam. And so we need to pull this all together and review management of the 4 scenarios for evaluating infants at less than 1 month of age. The 4 potential scenarios include proven, highly probable, possible, they're proven or highly probable, possible, less likely, and unlikely. These scenarios each help us decide what evaluation and treatment is necessary for the baby. I think that proven or highly probable is the easiest. In the case of a mother who tested positive during pregnancy, if the patient has an abnormal physical exam consistent with congenital syphilis, a serum titer greater than or equal to 4 times the maternal titer, or evidence of direct detection of treponema pallidum, the patient has proven or highly probable congenital syphilis. And because it's proven or highly probable, the workup that's recommended is extensive. This includes a CSF analysis for all patients, a CBC with differential, and a variety of other tests as clinically indicated, including long bone x-rays, chest x-rays, liver function tests, neuroimaging, eye and hearing exams. In general, we do a lot of this workup for patients with proven or highly probable congenital syphilis. In terms of treatment, the general treatment is penicillin G 50,000 units per kilogram every 12 hours for the first 7 days of life, and every 8 hours thereafter for a total of 10 days of therapy. Because this is proven or probable treatment, the entire course should be with penicillin, and if more than 1 day of therapy is missed, the entire course should be restarted. An alternative therapy that I won't keep mentioning, but will be an option in any of these cases, is procaine penicillin for 10 days. While an option to do, it's not ideal to do an intramuscular injection every day for 10 days, but it has been occasionally used, notably during previous penicillin shortages. Our second scenario is possible, and this one gets a little more complicated. It starts with a mom testing positive during pregnancy. In this case, the baby has a normal physical exam and a reassuring serum quantitative non-treponemal titer that is either less than or equal to 4 times the maternal titer. But there are one of the following concerns. Mom was not treated, or mom was inadequately treated. Mom has no documentation of having received treatment, and mom received treatment less than 4 weeks before delivery. In the possible category, recommended workup includes a CSF analysis, CBC with differential, and long bone radiographs. In terms of treatment, there's 2 options here. The first option is very similar to those with proven or probable congenital syphilis, and it's intravenous penicillin G, 50,000 units per kg per dose IV for a total of 10 days. However, in this case, there is a second option of Pen G 50,000 units as a single IM dose. So obviously everyone would prefer a single dose rather than 10 days of IV therapy. So how do you choose between these 2? Well, you should choose 10 days of treatment if the workup is abnormal. The workup is uninterpretable. For example, the CSF is contaminated with blood. The workup is not performed, as for example, in some cases, you may just elect to perform to do 10 days of therapy and not perform the workup. Or there's uncertain follow-up. I will also add that neonates born to mothers with untreated syphilis at the time of delivery are at increased risk for congenital syphilis, and a complete IV course may be considered, even if the evaluation is normal. So going back to the case of Jen, the baby was born at 34 weeks gestation via C-section for fetal distress that required only stimulation with APGARs of 7 and 9. The baby was appropriate for gestational age. The baby's RPR titer was 1 to 2, compared to mom's titer of 1 to 8, down from 1 to 16 3 weeks ago when she was treated. However, given that mom was treated less than 4 weeks prior to delivery, even though the treatment regimen was appropriate for stage, This baby falls into the possible category. In this case, a workup was attempted, but unsuccessful due to a bloody LP, and the baby was treated with 10 days of IV penicillin. The baby initially got 48 hours of amp and gent for rule out sepsis, followed by the full 10-day course of IV penicillin. The third scenario is that of a normal physical exam. Serum quantitative and non-treponemal serologic titer less than 4-fold the maternal titer. And mom was treated appropriately during pregnancy. Treatment was greater than 4 weeks before delivery, and mom has no evidence of reinfection or relapse. In this case, because it's less likely, no evaluation is recommended. And there are two treatment options. One is PenG 50,000 units per kg per dose times 1, which in general is my preferred option. And a second approach involves not treating the infant, but rather providing close serologic follow-up every 2 to 3 months for 6 months. This is a more intensive approach, but is a reasonable option. And this is what happened with Eve, whose baby was born healthy at 38 weeks gestation via normal spontaneous vaginal delivery. The baby's RPR was 1-to-1. And given that mom was adequately treated more than 4 weeks before delivery, we gave the baby a single dose of penicillin G. And finally, the last scenario, unlikely. And in this case, the baby has a normal physical exam and serum quantitative non-treponemal titer less than 4-fold the maternal titer, and both of the following. Mother's treatment was adequate before pregnancy, and mother's non-treponemal serologic titer remained low and stable during pregnancy and delivery. This is the example of somebody with a serofast RPR who may have had syphilis before pregnancy, was adequately treated, but maintains a low-level positive RPR. In this case, no evaluation is recommended and no treatment is recommended. For neonates with a reactive non-treponemal test, they should receive careful follow-up exams and serologic testing every 2 to 3 months until the test becomes non-reactive. In the case of patients not treated at birth, because congenital syphilis was less likely or unlikely, non-treponemal antibody titers should decline by age 3 months and be non-reactive by 6 months, indicating that the reactive test was caused by a passive transfer of maternal antibodies. At 6 months, if the non-treponemal test is non-reactive, no further evaluation or treatment is needed. If it's still reactive, the infant may be infected and should be treated with a 10-day course. For neonates treated at birth, the non-treponemal titer should be non-reactive by 12 months. If it's still reactive, consider an LP and a 10-day course of IV penicillin. For neonates with a negative non-treponemal test at birth, whose mothers are seroreactive, they should be retested at 3 months to rule out the incubation period. As a reminder, direct treponemal tests are not used to evaluate treatment because the results are qualitative and passive transfer of maternal antibodies can persist for over a year. For neonates with an abnormal CSF, they do not need repeat lumbar punctures unless they exhibit persistent non-treponemal serologic test titers at age 6 to 12 months. For persistent non-treponemal titers and CSF abnormalities, they should be managed in consultation with an expert who may consider whether they would benefit from additional courses of treatment. Now, that covers most of the common scenarios of children in their first 30 days of life, but we haven't discussed everything. Occasionally, you may get a patient over 1 month of age to evaluate for congenital syphilis. These are generally infants and children who are found to have reactive serologic tests when they are older than 1 month. The first step in separating out congenital syphilis from the potential of later acquired, is separating out congenital syphilis from the potential of later acquired syphilis, which requires a careful review of the records showing that congenital syphilis is possible. One thing that we always have to rule out is the possibility of abuse. If congenital syphilis is possible, then an extensive evaluation should be completed, including CSF analysis, CBC, and other tests as clinically indicated, very similar to what we have for our proven or probable congenital syphilis cases. The patient should be treated with either IV penicillin for 10 days if the workup is abnormal, or if the workup is abnormal, 3 doses of intramuscular penicillin G 1 week apart, just like we would do for latent syphilis of unknown duration. The reason to do all this workup and treatment is that untreated infants, regardless of whether they have manifestations in early infancy, may develop late manifestations, which appear after 2 years of age and involve the central nervous system, bones, joints, teeth, eyes, and skin. Some consequences of intrauterine infection may not become apparent until many years after birth. Things such as interstitial keratitis, 5 to 20 years of age, eighth cranial nerve deafness, 10 to 40 years of age, Hutchinson's teeth, anterior bowing of the shins, frontal bossing, and other symptoms can all occur late in this process. But late manifestations can be prevented by treatment of early infection, which is why we discussed so many different options today. So I know that was a lot of information, and congenital syphilis is hard. And so I've saved about 15 minutes to take any questions. Before I get to questions, I just want to remind people of our upcoming sessions. We have some amazing guest speakers coming up. On March, we have the person from Massachusetts who helped identify the new gonorrhea strain coming to talk to us. In April, we have someone from Montefiore coming to talk about neonatal herpes and herpes. And then in May, we have the PIDS Fellows case presentation, where we're looking for interesting STI cases from fellows and residents. So please submit your cases now. And with that, I'll stop and take any questions. Thank you very much.
Thanks so much, Dr. Zucker, for your presentation. Dr. New, I know you've been answering a lot of the questions that have been coming in. I don't know if you want to sort of continue with where you left off.
There's a question about using ampicillin towards the 10-day course for treatment for congenital syphilis.
So ampicillin does not count towards the 10-day course of treatment. You should restart the count when they get switched to penicillin. We had one case in here that was an example of that, where the patient got amp and jet for a 48-hour rule out and then completed a full 10-day course of penicillin.
There are some great questions that might be good to talk about in general. There was a question about doing point of care testing for moms and babies. And I think that what I thought was that there's some variability in the point of care testing, but it might be useful in the setting of delivery and pregnancy. Do you have any comments about that?
Yeah, point of care testing has potential. The challenge is that most of the point of care tests are qualitative only and not quantitative. So for patients who may have had syphilis in the past, it doesn't tell you what their titer is currently. And I agree with you, it's also not as sensitive or specific as some of the blood tests. I think in cases of somebody who's about to deliver, where maybe you send out your RPRs and it may take longer to get a result back, there may be a benefit of having point of care testing as an option. However, it does not negate the need to also send off a proper RPR and testing.
I think there's just to bring some clarification around like what serofast means and interpreting titers. We can say if, a titer going from 1 to 2 to 1 to 4, that's within variable range. But if it does go 4-fold increase, we would consider that a new exposure or reinfection. But can you just comment a little bit about what serofast means?
Sure. So serofast are low level, usually less than 1 to 4, persistently positive titers that have not changed over time. So again, for many patients who have a positive RPR, particularly those who have a very high first RPR, their RPRs may actually never turn negative. They'll remain persistently positive, potentially forever. And so we consider that serofast when they're persistently positive, but the titers aren't changing. Somebody asked a question, I think before I got to it in the thing, but about the rate of RPR decrease. Just as a reminder that in pregnancy doesn't really last long enough for us to see the complete RPR decrease we would expect to see in a person who's not pregnant, because it can be over 1 to 2 years, as Dr. New said in her comment. So in pregnancy, the most important thing is confirming that maternal treatment was adequate, since you're not going to be able to confirm it based on titers.
Gabriella asked a really interesting question about and also Hani about the CSF studies. So, if somebody has a positive VDRL or a negative one, what is the duration of treatment? No, so for neurosyphilis, they have in the guidelines 10 to 14 days. For congenital syphilis, they say 10 days. But I think that you could vary the treatment up to 14 days for the positive VDRL. What are your thoughts about that?
I think that's very fair. I would probably err on the side of a little bit longer and do 14 days, although I don't believe that's specifically called out in the congenital syphilis guidelines. But I think I would treat it like neurosyphilis as well, just like you suggested.
And then somebody did mention also, Sarah, that sometimes it's difficult to get these tests back. So I'm not really sure how to handle that. You know, the RPRs and the babies. Sometimes I think you just have to, like you were mentioning, make sure that you have data from your Department of Health. So everyone, we recently worked with another group who had somebody was treated in a different state. So you can connect with the Department of Health at different states to find out whether the mother had adequate treatment, what the timing of the treatment was, what the RPR results were. We were able to put that group in touch with somebody in the California Department of Health. So those things are super important when sort of assessing if you can't get that RPR data back quickly enough. And sometimes you just have to stay in-house if you feel like you're not going to be able to get them back.
I think that's fair. You know, that's the Red Book says no baby should be discharged until you really have an answer about the maternal status. We have a couple of new questions now that just came in, maybe, and one I'd like to highlight for a second. So there's a question about, do we know how couple and family dynamic changes? So for example, if a partner and a mother treated during pregnancy and hence no risk of reinfection, or the partner not treated during pregnancy and hence risk of reinfection. You know, to be honest, if the partner is not treated, then you really do run the risk of reinfection if the mother is still sexually active with that same partner. And due to the long 90-day incubation period, I think it's really hard to say that the patient may not have congenital syphilis, and you have to at least do the single dose therapy that you would for probable syphilis with the complete workup. Otherwise, choosing the full 10-day course if you don't want to or can't do the complete workup.
I do think also it's really important to remind when you're in this situation and you're trying to assess, to remind the GYN providers and also the PIDS ID fellows, that people sometimes do not have unique partnerships, and others, you know, or somebody may have been away for a while and come back at the end of pregnancy and putting the pregnant woman at risk, or, you know, we've had several patients recently released from incarceration who then had sex within that short period of time prior to delivery, and the baby had congenital syphilis. So these are things that you really have to discuss with the women when you're doing your evaluation. I think there's, oh, you answered it.
Which one? We have a question about 4-month-old missed infant with bony lesions in upper lower extremities. Now status post-treatment, expectations regarding healing of these lesions, and discussions with the family regarding athletics in the future. I don't know, Dr. New, if you have any thoughts on that one.
I didn't till a week or 2 weeks ago. We had a case very similarly, late diagnosis. One of my colleagues, Crow and Pofo over in Utah, did mention they had a case with that. And when the baby was reevaluated for those after the treatment for those bony lesions over time, the bones had completely normalized. I would have to do a deeper dive into the literature to see if there is the support in that. But if the bones do normalize and mineralize, I think that athletics should not be a problem in the future. Have you seen something else, Jason?
No, I have actually seen almost nothing on that long term, other than that if you treat them early enough, the expectation is that they will be near normal. But that even that, there's not good data on that. And same with sort of the there's another question about the appropriate follow-up for infant for congenital syphilis in terms of developmental ophthalmology and skeletal abnormalities. In terms of ophthalmology and skeletal abnormalities, the expectation would be that they would improve once they were treated. and not continue to worsen. In terms of developmental, I think you really do need to get them into a developmental program to be evaluated on an ongoing basis. But I think it's very hard to assess that early on. Joanne Robinson just said, Pablo Sanchez advised no need for radiographic follow-up of bone lesions. And I agree, that's what he's told us before as well. I just have not seen the sort of data behind that, but I agree that most people expect that the bone lesions will not worsen once they're treated. Thoughts on what's driving the dramatic increase in cases? I don't know, Sonia, I wish I really knew. I don't know whether it's just we're doing a better job of screening than we were in the past and we're identifying more cases, or whether there truly is just more. I mean, we're seeing increases of STIs across the board, and syphilis gets transferred through that same way. So what's driving this sort of syndemic problem, I think, is a much bigger question. I don't think we have a really good answer to that one. Dr. Neal, anything from you?
Sex. People have sex, so.
More sex though than before?
I don't know. Yeah. And I think though with, I think people are having, I don't know. I don't know if it's more sex than before or having different partners. I think it's a sexual revolution kind of going on now that, but I do think we are screening more, and with all the information about STIs and that we are picking up on more cases. It's been a focus for the CDC, I will have to say.
For sure. There's a question about, do babies with congenital syphilis need hearing monitoring? So interestingly, babies with congenital syphilis were more likely to fail ABERs at birth. However, there was actually, I found this the other day, a really nice systematic review that did not find reports of children with confirmed sensorineural hearing loss secondary to in utero infection. They mainly recommend doing positive screening at birth. And then again, longitudinal screening just to ensure that they don't have any further hearing issues.
Really funny, like for a disease that's been, not funny, but it's interesting that for a disease that's been around for so long, like we really don't have data on some of the long-term outcomes, you know, because this disease, you would have to monitor them for years, and we don't have that.
Mm-hmm. What is a plausible explanation for relatively quick reinfection in someone who was adequately treated and should have experienced an immune response, not protective? Oh, this really goes down a really deep rabbit hole. And I say rabbit half jokingly because most of the animal models are in rabbits. The period of time that you're immune to syphilis after an infection is a mystery to me. Me and one of my colleagues dove deep into this one time, and I think it's very unclear what type of expected protective response you should have from syphilis and how long it may or may not last. It may also be impacted by how quickly you're treated and other things. So I just don't think we have a great answer for that. In terms of not counting ampicillin for syphilis therapy, is this a lack of data or historical inertia issue? Probably both. I mean, essentially, we don't have data for anything in syphilis, and so the recommendation remains penicillin. You know, there's an ongoing study looking at ceftriaxone and other things, which I think would allow us to maybe consider alternative antibiotic options, but we don't have data for that now. And in sort of the setting of such a potentially severe disease and such sort of an, I don't know, easy option of using penicillin, it is challenging to sort of move away from that. I don't think there'd be necessarily, it would not be an easy trial to do because it wouldn't necessarily be equipoised for using something other than penicillin. In terms of, is there any actual data supporting the requirement for blood versus cord blood? I would guess it's mainly theoretical. However, it would make sense that the maternal blood is in cord blood. And so if you're trying to get the neonates RPR, not mix that with moms, it makes sense that you would need neonatal blood. I don't know if there's been a study of that or not, but it does make a lot of sense.
Great. Well, I think that was a very good discussion, and we had a lot of questions and conversations around this. We have just a few minutes left. Any last thoughts from you, Dr. New or Dr. Zucker?
I do want to make sure that everybody on this call today really takes advantage of our case presentation series that's going to happen in May. You should be getting from PIDS an invitation to submit your case with, it's going to be using the template like for the IDSA case pediatric series. And it's going to be super fun. You will be able to present yourself on this national forum, and we will highlight you in our newsletter. So I invite you all to submit your cases of interesting STI cases that you've encountered.
Great, thanks so much, Dr. New. We have one last question, and the question is, any new tests in the horizon?
For syphilis, I am not aware of any. How about you, Jason?
Not at the close enough level to be meaningful. You know, there's some people who've been doing sequencing. There was that paper out of the University of Washington recently that looked at like deep sequencing for syphilis. I don't think any of these are anywhere near the clinic. These are more research and other assays, nowhere that looks to be near the clinical side of care.
It's an area where you can bring your interest and your research, all of you ID fellows out there. Thank you, Jason, once again for an amazing talk. And thank you to our audience for all your great questions. It definitely helps us to keep our sessions interesting.
Well, thanks everyone for attending, and hope to see you all at the next session in March.
Thanks, everybody.
Thank you.